Yeah, you are live. Sagar, you can start.
Yes, sir, definitely. So, first of all, I thank Dr. JP sir, Dr. Raju Reddy sir, and all the seniors that for giving me this opportunity because this is certainly regarding the
Live.
basics of.
Sagar, you can start. One
Yes,
minute.
sir, definitely. So, first of all, I thank Dr. JP sir, Dr. Raju Reddy sir, and all the seniors that for giving me this opportunity because this is certainly regarding the
Live.
basics of.
Sagar, you can start. One
Yes,
minute.
sir, definitely. So, first of all, I thank Dr. JP sir, Dr. Raju Reddy sir, and
Sagar,
all
wait.
the
Sagar,
seniors
wait.
that for giving me this opportunity
Sagar,
because
wait.
sir,
This
वो
is
echo हो रहा है.
echoing,
Certainly
echoing,
regarding
echoing. It is
the
echoing. 1 minute.
yes, yes, sir.
You can start. One minute.
Yes, sir, definitely. So, first of all, I thank Dr. JP sir, Dr. Raju Reddy sir, and
Sagar,
all
wait.
the
Sagar,
seniors
wait.
that for giving me this opportunity
Sagar,
because
wait.
sir, वो echo हो रहा है. Certainly
Echoing,
regarding
echoing. It is
the
echoing. 1 minute.
yes, yes, sir.
You can start. One
Yes,
minute.
sir, definitely. So, first of all, I thank Dr. JP sir, Dr. Raju Reddy sir, and
Sagar,
all
wait.
the
Sagar,
seniors
wait.
that for giving me this
Sagar,
because
wait.
sir, वो echo हो रहा है. Certainly
Echoing,
regarding
echoing. It is echoing. 1 minute.
yes, yes, sir.
You can start. One
Yes,
minute.
sir, definitely. So, first of all, I thank Dr. JP sir, Dr. Raju Reddy sir, and all the seniors that for giving me this
Sagar,
because
Sagar,
yes, sir.
now you can go on. You can
Yes,
go
sir,
on.
sir. वो echo हो रहा था. Then I thought,
Yeah. That's why.
हाँ, sir.
See, what has happened is that this it is coming. I mean, because it is coming on both. It was on. YouTube was on my desktop also. So it's now you can go on. There will
Yes,
not
sir,
be echoes.
definitely.
Yeah.
I thank Dr. JP sir, Dr. Raju Reddy sir, and whole Bettadur, alumni and all the seniors for giving me this opportunity today. This is basically based on the basics of endometriosis surgery. It includes from how we at the Institute Mayflower, Dr. Sanjay Patil sir has catered and made this so easy to approach the endometriosis cases. I have been working with Sanjay Patil sir since 2 years now, and I worked with JP sir with for a year at Bettadur Hospital. The thing is that endometriosis is being a multisystemic disease. We all should know that the start to endometriosis approach starts from an acceptance of a fact that this requires a multidisciplinary team. And Sanjay sir always says that. बहादुरी का कोई मेडल नहीं होता है. So the thing is that as it is a multisystemic disease, it is important to have the certain fertility with us and to along with us. The thing is that it starts from a radiologist, it includes gynecologist, it includes the GI surgeon, and it also includes the urologist in most of the times. Although the requirement of during the modern days, when we speak about the endometriosis, the organ preserving surgery has becoming a more and more has come forward with this thing when where the radical approach is slowly going down, but still having these people will give us a security, and with a proper team we can give justice to the patients of endometriosis. Now when coming to the basics of the endometriosis, we always say that this team plays a very significant role in performing these endometriosis surgeries. Now the first question comes is that where to start, where when the patient walks into your OPD into for the cases of endometriosis. Regarding if it's a tertiary care center, then we need not worry. But if it is a center where if you are practicing and the patient most probably come with a pelvic pain or they come with an infertility. So basically, being a gynecologist, it is important to understand how we are going to diagnose these cases. And when we can diagnose these cases, then only we will be able to approach these cases. The diagnosis initially includes the typical history of dysmenorrhea, pelvic pain, and infertility. These three are the set of things that usually patients present with. And in these patients, doing a transvaginal ultrasound is the basic modality that one should have. And one should know how to do a TVS, at least a basic TVS in a patient's should do their own TVS. That's what I always suggest. So by doing TVS, there are three things that you should generally observe. One is the presence of chocolate cyst, that is the cyst with a ground glass appearance and a frozen pelvis and a negative sliding sign. These three are the important things to at least categorize it under the endometriosis. Once you have endometriosis, you can ask me that whether is there any investigation that we can do. Although CA 125 is there, it is not so specific, so I don't recommend it most of the times. And the thing is that here also we don't recommend it. And the thing is that
Endometriosis ನೋಡ್ತಾ ಇದ್ದೀನಿ.
and once we diagnose this as an endometriosis,
ಬರ್ಲಿಲ್ಲ ಅಪ್ಪ.
the next thing is that we have to go for an MRI. That's what we follow here. Whatever the patients come initially diagnosed with an endometriosis, as it is a tertiary care center for endometriosis, here most of the comes, they before coming only, they will be knowing that they will be having an endometriosis. But once you see that transvaginal ultrasound, there is an endometriosis, it is better to go for an MRI. Although it is a point of discussion when it comes to Raju sir may differ it, but still I say that what we follow here is that MRI is the basic thing that we are going to do. Why MRI is important in these patients is because of two things. One is we will be able to clearly map the disease, both pelvic and extra pelvic. Second thing is that once we have the MRI images in your hand, it becomes so easy to counsel these patients that you have this disease. Now we are going to do this much. And because it involves ureters, it involves the bowel, and also sometimes most of the times it involves the appendix. Once we have this disease, once we have this MRI in our hand, patient counseling becomes much more easier compared to just doing a transvaginal ultrasound and then images. Once the patients are properly counseled regarding what can happen with their body, then the acceptance of the disease, acceptance of the surgery becomes much more easier. And as a pre-operative workup here, we just do basic investigations, and the pre-operative bowel preparation is specifically here, it includes only giving 2 Dulcolex tablets in the 1 day before the night, and patient is allowed to have liquids till the morning. Why only Dulcolex? Why not Peglet? That is also a good question. But the Dulcolex makes as a stools as a solid component. Even if we are opening the bowel, the chances of spillage is very, very less compared to Peglet. So it is better to give a Dulcolex in these patients. Now coming to the basics of this surgery, this is where the two things that anyone who wants to approach a case of endometriosis, these two things are very much necessary. One is sigmoid adhesiolysis, second thing is ovarian adhesiolysis. Why we should do sigmoid adhesiolysis? Sigmoid adhesiolysis will give us three important things. One is the mobility of the bowel will become much more easier. Why we should mobilize the bowel? Because if pelvic is a narrow space, if we want to access the both side of the pelvis, and if we want to if we want to do any procedure with the colon, bowel mobilization is much more important. And hence this sigmoid adhesiolysis is the basics of any endometriosis surgery. And for freshers, this sigmoid adhesiolysis will give a much more confidence if we start from this level, because this is the start of many more beautiful things. And second thing is that why we should mobilize this sigmoid colon is that here we can expose the infundibulopelvic ligament, and also we will be able to approach the left ureter from the pelvic brim. And hence this sigmoid, and how much should be done? It depends from case to case. Suppose if ureter is clearly visible and if there is no much of the colonic resection is required in these cases, or colonic dissection is not required, then it is only small amount of sigmoid adhesiolysis is more than enough. Now coming to the ovarian adhesiolysis, the point of the question is whether we should do a blunt dissection or a sharp dissection. See, one thing we have to understand is that whenever there is adhesions between a ovary and the peritoneum that is there in the ovarian fossa, there is always a peritoneum in between, and any important structures or any retroperitoneal structures are below this peritoneum. So whenever we do a ovarian adhesiolysis, it is important to understand that injuring these structures is very rare. Like, I mean, if you are staying above the peritoneum, the chance become very rare. For example, in this case, if you can see here, this right ovary is very much fixed to ovarian fossa, and there are dense adhesions at certain points. If you start working with the tip of the instrument, and also right instrumentation plays a significant role in these cases, but if you are very much, you start using with the tip of the peritoneum and with a proper counter traction and traction, these cases become much more easier. So if you are dividing very close to the ovary, and if you start dissecting this peritoneum with both blunt and sharp dissection, that would be very much more helpful. And even the carbon dioxide gas that we use, that will be act as a mediator, and it will start expanding the spaces once you start opening. For example, here, if you open the spaces here, you can clearly see that we are staying above the peritoneum and we are staying above it. And I use both sharp and blunt dissection here. You can see the sharp and blunt dissection here. And why we should do the sharp dissection combined with the blunt dissection is that chances of bleedings will become less, chances of staining of tissue will become less. And we all know that endometriosis is a disease which includes both the inflammation and neovascularization. It is not a cancerous tissue, but still it behaves like a cancerous tissue, which has both neovascularization and the inflammation. So using this approach of my blunt and sharp dissection will be helpful to minimize the staining of the tissue. And we also should remember the predictive anatomy that comes to this place. And we all should know that if we stay above this peritoneum, chances of injuring any structure is very much less. And if you can see here, I am trying to be as close as possible to the ovary. And I also, if you can observe, I was just opened the peritoneum over there. So I just changed my plan. I started again and I gave a proper traction and I started opening it again. So now the thing is that by doing this, we achieve two things. As I told, one is we will be able to have a bloodless field, which will also make look surgery good. If you can see here, I am giving a blunt dissection followed by, I am understanding that, yes, now we will be giving a proper traction and a dissection to this thing. And by this method, chances of injuring the ureter, which is more, which more commonly injured during these procedures, is very much minimalized. And I am going I made sure that I opened the peritoneum and I am going close to the ovary so that I dissect that peritoneum off. By this way, we can free the ovaries. And by the way, this patient has come to me with a complaint of, not able to conceive since 3 years. And with TVS, I did the TVS and I was able to diagnose there is a dense adhesions. Although I did MRI in this patient, as patient was a well-to-do patient, and as I did MRI, there was not much of the disease. This surgery was done with a 2 ports only, where third assistant was not required. And this patient conceived this month. And coming to the next point is that what are the mathematics that is there in the radical endometriosis surgery? Is there any mathematics, or we should follow any certain steps, which usually Dr. Sanjay Patil sir has taught us, is that there are certain things that we should always keep in mind. Whenever we do a surgery, we should take care of these things. One thing is that we should safeguard both the ureters, we should know about the idea of retroperitoneum, and we should be able to dissect the spaces. Debulking. Debulking here refers to mainly debulking of the tubo-ovarian mass. Means I am just speaking about, as this lecture is about basics and radical surgery. Debulking here refers to debulking of the both tubo-ovarian mass, where we are removing both the ovarian component and the nerve sparing. Here, hypogastric nerve in these cases should be spared because that will retain the bladder functions and bowel functions better for the patient. Now, if you can see here, this is a case of grade 4 endometriosis. She was 46-year-old and came to me with complaints of severe dysmenorrhea and persistent bleeding and severe pelvic pain. Now, if you can see here, there are clearly adhesions between the bowel and the left tubo-ovarian mass, which has chocolate cyst. Now, the point comes that whether we should deflate whether we should first open the cyst and drain out the chocolate fluid here, or whether we should just go with whatever the cyst is there. If cyst is very much more big in size, for example, if it is 10 centimeter, if it is occupying pelvis, if it is obstructing the field, then it is better to go for an debulking. Suppose if it is not, then we should act it as we can actually use it as traction and counter traction in a better way if cyst is filled. And cyst is always have a dependent point where it usually opens up, where the thinnest portion is there. That is usually there just above the ureter. That is the point that we should remember. And if you can see here, I am staying above the peritoneum here. so that the retroperitoneal structures are not damaged. And second thing is that I'm using this cyst as a traction and counter traction. And always, as our JP sir and everyone tells that fat belongs to bladder and fat belongs to bowel, I'm keeping in mind that I'm staying that. Now, when to go for these central adhesions? Like, is it direct approach or we should directly go for a central adhesions? The trick to central adhesions is that once we dissect the both edges and once we know that the ureter is below, the central adhesions should be dissected till the level of where you dissected the ovary on both sides. And central adhesions, while dissecting it, there is always a adhesion. There is always an endometriotic nodule that is there between the colon and the rectovaginal plate, or the area just above the both the uterosacral insertion. There is always a dense endometriotic nodule here, which is the most common part that is involved. So here, the key is that you have to split this nodule. The splitting of this nodule makes a less chances, and it is a tactile sensation. Basically, you have this nodule is very hard. If you can see here, even the harmonic is getting difficult to cut this nodule. So by splitting this nodule, we will be able to split the nodule half towards the uterus side and half towards the colonic side, which can be exercised separately later. And once the purpose is served, and as I have to dissect the area that is there below the ovaries, it is important to dissect the ureter and understand how much is the where is the ureter and its position. So in ureteric dissection, as there are various levels of ureteric dissection, but this is the basic ureteric dissection where you open just above the ureter, you open a peritoneum just above the ureter and let the carbon dioxide do the rest of the things for you. This will give it, just open it vertically and tease it laterally and cut. So that will help you to open the spaces. And once I know that the ureter till the tunnel, now I will be able to dissect the tubo-ovarian mass from the rest of the peritoneum. Once this peritoneum is removed, the next thing comes is debulking. Debulking here refers, as I told, dissecting and coagulating the infundibulopelvic ligament and removing this whole tubo-ovarian mass. As patient was all nearly menopause, and there is no point in keeping ovaries with this kind of chocolate cyst. To prevent the recurrence, it is better to go for a debulking. Here we are making a window between the ureter and the infundibulopelvic ligament so that we can cut and clamp it with using a ligature. The staining of the tissues can be minimized by giving a pitrusin before the surgery. That will help in more probably in conservative surgeries compared to radical surgeries. Or if you
भाजी गरम झाली का हे कर
if you are expecting a dense adhesions, then it would be helpful. Now, if you can see here, compared to the left ureter, right ureter has shifted more laterally this side on the right side, and peritoneum over here is thick compared to the left side. There are possibilities that one side of the ureter is more densely involved, and there are possibilities that one side of the ureter is not at all involved. Now, if you can see here, this is the right ureter, and I am dissecting the peritoneum over it, and I am making sure that ureter is safe and it's entering till it entering the tunnel. And once we are sure of it, I am again making a window on the right side to remove the right tubo-ovarian mass by coagulating and dissecting the right infundibulopelvic ligament. Here, point to be remembered is that although this peritoneum is inflamed, we have to remove, in conservative surgeries, it matters most because we have to remove this inflamed peritoneum so that new peritonization could happen. Why to be removed? Why this peritoneum has to be removed is that this peritoneum is susceptible to chronic inflammation. There has been a persistent inflammation which can impact the embryo implantation during the pregnancy. Now, if you can see here, I am dissecting in the right medial pararectal space where, as I told, there is the fat belongs to the bladder, and bowel. Here, I am just dissecting the both media pararectal space, and then again, I am coming back to the central adhesions. By this approach, we are minimalizing the damage to the hypogastric nerve. We are minimalizing the damage to the colon. So once I am sure that I am dissected the central adhesions, I am removing the excessive peritoneum that is there, which is inflamed and which is not good. And again, I am removing the rectovaginal plate that is there. If you can see here, I am holding in right side, there is a right hypogastric nerve. There is disease about it, and we are just shaving it off from the hypogastric nerve. And this nodule, as I told before, this is always present between as a rectovaginal plate just above the uterosacral insertions. That is the most common area. This nodule has to be removed before performing TLH, because that will also give mobility for the uterus, and you can act as a helps in traction and contractions. If you can see here, I'm opening the denonvular fascia here to make sure that the final end of central adhesions are completely removed. The head one is the vagina and posterior one is the rectum. After this, the thing is that we go for a routine hysterectomy. It includes the routine steps while performing the hysterectomy. So removing all the nodules before performing hysterectomy is very important, because once we remove the uterus, we don't get enough traction and countertraction. So it is better, while before performing the uterus, we have to, before performing the TLH, it is important us to remove all the endometriotic nodules that is there possible. And once all these things are done, it is a simple hysterectomy for, routine. It can act as a routine hysterectomy. We use here clementfuran for routine colpotomy. And once colpotomy is done, all the tissues removed through the vagina, and then appendix is examined. And appendix is the most common extrapelvic site that is most commonly involved in these cases. So one should always see the appendix. One should always see the diaphragm once to see if there is any endometriotic deposits. So and once it is done, it is sutured through V-lock. Now you can clearly see that both ureters are freed up, all the disease is removed, and vault is sutured. Now, after these procedures, even in the simple TLH, Sanjay sir always advises us to do cystoscopy, because it will give us a sense of confidence before, and avoid any surprises. A clear jet of urine from both the ureteric orifices, that would suffice, gives a lot of sense of confidence that we are not injured. Any blood stained urine, and also we can, by doing cystoscopy in endometriosis, we can also find if there is any existing endometriotic nodules in the bladder, which is, less likely we going to get once we have done an MRI. So by this clear jet, we can clearly notify that, ureters are not injured. This is about this basics of endometriosis surgeries.
Thank you. Thank you. And it's a very nice and clean surgery. Very proud of you.
Thank you, sir. Thank you so much.
Thank you. Few questions.
Yes, sir.
Number one, I request Ashish Bhau also to, unmute and be prepared for the discussion and questions.
Yes,
Okay.
Vidyasagar.
Sir.
The first question is from my side.
Yes, sir. Yes, sir.
Please explain the concept of splitting the nodule into halves.
Yes,
Why
sir.
not to keep it with uterus
Yes, sir.
and cervix, or why not to keep it completely with the bowel, that is the rectum or sigmoid?
Yes, sir. Definitely, sir. Sir, now the concept of splitting comes when, will be more helpful when there is a big nodule that is involving even the vaginal part also, sir. Most of the times it will be involving cervix. Most of the times it will be involving the vagina also. So when we split the nodule, half of the nodule will be going towards the uterine side, half of the nodule will be coming to the colon side. Now, why half of it? It is not exactly half of it, but part of the nodule will be going to that side, and part of the nodule will be going to this side. This nodule is hard in consistency, and if we want to remove this nodule from the vagina, we need a good traction. So if we have this chunk of the nodule that is there, then we can give a proper traction and counter traction in dissecting this nodule, even from the medial to the ureter also, and even from the lower part of the vagina also. That would help us in dissecting that. And second thing is that the chances of injuring the colon will become much more lesser, sir, because whenever there is a nodule, if we are splitting the nodule, we know that half of the part of is going to fall out with the rectum, which we can later dissect and remove either by a shaving or by a discoid, or most of the times it will come to it. Only less than 2% of the cases will go for resection and anastomosis.
Sagar.
Yes, sir.
This levels of ureteric dissection.
Yes, sir.
course, I've seen Smith's video on that.
Sir.
Okay, I was recently I was showing my colleagues, like, if at all you just want to see the ureter, like, you want to dissect it the way you did it in this case,
Yes, sir.
you know that ureter is not really involved.
Yes,
Okay.
sir.
So what happens is you leave the whole mesoureter on the ureter and you just want to split the peritoneum over the ureter to keep it in vision.
Yes, sir. Yes.
That is one purpose.
Yes.
Whereas if at all, like, you know that ureter is involved, like you have a hydro or anything. Now what you do is you go into that one fascia which covers the ureter.
Yes.
And enter through that, and then because the endometriosis has actually engulfed that fascia.
Yes, sir. Yes.
And it has engulfed the the mesoureter. So in those cases, what you do is you enter that fascia and then only you almost strip the mesoureter at that level where it is exactly involved. Okay.
Yes. Yes.
Now there may be
Constriction level.
some in such situations where you enter that mesoureter and then split up. So there will be possibilities of compromising on the blood supply.
Yes, definitely, sir.
So in such cases, what I'm asking is, now whenever there is a narrowing of the ureter with the complete involvement of the endometriosis, and then how do you decide whether this patient requires stenting, doesn't require stenting, or it requires resection anastomosis? What are the things which tells you, yes, this patient is for any of these procedure?
Okay. Basically, sir, we are speaking about here parametrial involvement
Yes.
in the endometriosis, right?
Correct.
So now what happens is that whenever there is a patient with a parametrial, as I told before also, the involvement of one side of ureter can be more, one side can be less. This is a possibility in endometriosis.
Yes.
Because this is like that. So now whenever we see a gross hydroureter nephrosis, if it is on one side and one side of the ureter is there is no hydroureter nephrosis, we need not worry much. Suppose if there is a gross hydroureter nephrosis and we can see a constriction that is there, then it is better we do renal functional scan here. Suppose if we feel a gross constriction at the level, we do a renal functional scans. Technetium 99 DTPS scan is most probably preferred, and we see how much each kidney is functioning. Suppose if kidney function is more than 11%, then we need not worry. Whatever we are doing, either it is an implantation or it is an just ureteric shaving, all those things matter. So now if kidney function is less than 11%, if patient is very young, and if kidney function is nil, then we can't do anything. Suppose if it is between 9 to 11%, then we can give a chance that we can just do a procedure where we can just retain this kidney and we can wait for 6 months whether this is going to come back to its function or not. As one kidney is more than enough, patient sometimes even presents with nil kidney function on one side. And the ultimate choice for this patient would be nephrectomy. So now coming to your question, sir, where the decision will be, it depends on how severe is the constriction here. Basically, if whether intrinsic, only implantation point is that if there is an intrinsic involvement, then only we will go for an implantation. Whatever may be the severity of the involvement from the extrinsic part, most of the times, 95% of the times, this is extrinsic involvement. Very rarely I have seen there is an intrinsic involvement of the ureter. So when there is an extrinsic involvement, we try to, just like when we come to the closest part of the adhesion, or where we come to the closest part of the constriction, ureter should be mobilized from all the 360-degree way, and the nodule has to be split. And here Caesar comes to a role compared to harmonic instrument. And once we do this, we know that part of the constriction is going to be vascularized. I mean, like the vascularization will be much more less compared to the other part of the ureter. Just do a stenting at this part and come out. And most of the times you don't require any kind of other interventions in these cases. And that would be more than suffice. Suppose if there is an intrinsic involvement, definitely then we should go for an implantation.
Okay. Now, we were discussing, like I and Anil Magdoom and Ashish Kubde, about the rectal shaving vis-a-vis with discoid vis-a-vis with resection anastomosis.
Yes, sir.
Okay. Now, it is of course clear that if there are proper obstructive symptoms and patient has a bloating and all that, she will, and the involvement is more, and I mean the length of this thing, then she may be opted for resection anastomosis.
Yes, yes.
Now, you tell me, what are the factors for and against discoid vis-a-vis shaving? Number one. Number two, is there any change in the thought process of late of doing more conservative compared to more radical?
Yes, yes, definitely, sir. Nowadays, Sanjay sir is more towards the organ preserving surgeries because this will prevent a lot of, you might have heard of Lars syndrome also, which is more common if we go for a resection and anastomosis. So it is better to go for a conservative procedure, and most of these patients are young and they have a whole life ahead of them. So it is better to go for a conservative surgery and give a chance that this could help them. So now the point of shaving, discoid, and resection comes with simple thing. Sir says that if the circumferential involvement of the bowel is more than 30%, then most of the times this will go for an resection and anastomosis. But the depth of the involvement also matters. Suppose if this nodule, most of the times when the nodule you see, it is more on the outer side, as it invades inside, the length of it or the size of it goes on decreasing. Hence, we describe it most of the times it as a mushroom shaped nodule because it looks like that. When it starts invading inside, the nodule size goes on decreasing. Suppose if it is involving the mucosa of it, and if it is less than 3 centimeter, most of the times it goes for a discoid resection. Suppose if it is not involving mucosa, if it is involving muscularis and above that, so most of the times it will go for a shaving. Suppose if it is more than 3 centimeter nodule, the inside, and more than 30% of the circumference is involved, and if there are multiple nodules on the segment, then definitely it will go for a resection and anastomosis.
Okay. Any comments, Ashish sir and Anil bhai? Or any other questions? Anyone?
Vidya,
Sir,
Vidya,
sir,
if you are having a nail and hammer,
yes, sir.
always your mind goes for fixing the nail with something.
Yes, sir.
If you know all these procedures, means if you are mastering, if you have already mastered these procedures of shaving with nose, with rectal, this anastomosis,
Yes, sir.
do you think that this incidence of this rectal endometriosis कि हम उसको ज्यादा परसीव कर रहे हैं, ऐसा कहीं, यानी whether it is increasing, do you think?
Sir, it is basically, see, sir, endometriosis, we started getting to know better. This is a modern disease, basically. The incidence has definitely increased. And now the modalities of diagnosis, like MRI, finding MRI, because we use endometriosis protocol, everywhere it is followed now, where they put rectal jellies, where they put vaginal jellies to identify these nodules better. And definitely increase in the sensitivity, increase in understanding of this disease, increased in the awareness among the doctors has led to increased knowing. First they used to think that yeah, it is just a fibrosis and leave it off, but nowadays they don't think that, they feel they may be endometriosis, and now they know about the disease, sir, and definitely idea about this has increased, the more awareness regarding this disease, and hence they are going for and everyone nowadays in CMEs and everything, there has been a lot of talk about endometriosis. Now this is this disease is the disease of this generation, where people talk more about it. Surgeons like to show this disease, how it is done, why they are doing. So now, because of all these things, definitely, sir, as you said, the awareness has increased and people are going more towards this shaving, rectal, discoids, and resection and anastomosis.
With that, the other part of my question is,
Yes, sir.
how many the complications you have witnessed about this either of shaving or this segmental resection or the complete resection anastomosis?
Yes.
Because whenever there are complications of either rectum or rectosigmoid,
Yes, sir.
These are very deadly complications.
Yes, definitely,
These
sir.
complications, management of complications, either complications or management of complications, the magnitude is always bigger than that of the endometriotic surgery.
Definitely, sir.
So, how many complications you have encountered,
Yes,
or whether the other part of my question is whether this dealing or hyperreacting this rectal endometriosis, is it a fad today?
I don't think so, sir, because removing this nodule is much more important. Suppose if patient is basically a young patient who is looking for infertility, and if this disease is very much less in endometriosis, it is better to remove at that point only, and not to wait until it invades inside and go for it. Now, and coming to the complications, sir, most of the times when we do shaving or when we do discoid, we keep a drain, and we observe how the patient is going to respond. In these last 2 years, there is only one patient that I have encountered that too underwent ileostomy because of this leak. And even with resection and anastomosis, and since 2 years, whatever the resection and anastomosis we have done, I have not seen in even a single leak. The leak happened in one case because of the injury to the colon, and definitely that has to be converted into a ileostomy during that period.
So, for example, can you quantify out of 100 endometriosis cases, you said 2% goes for resection anastomosis.
Yes.
The
Yes, sir.
remaining 98, how many discoids and how many shavings?
Most of them go for shaving only, sir. If you compare, you can take it as like 10% of them only go for discoid. Rest of them go for a shaving only, sir. Because the involvement of mucosa is very, very, very less, sir, compared to, it depends on the how long is this has been growing. But definitely, believe me, sir, this is most of the times it goes within shaving. You need not do anything else. Just shave it and suture vertically.
Okay. And do you people use ICG, indocyanine green, for shaving or after discoid to see the blood supply?
Nothing, sir. Nothing. We are
No,
not yet using anything like that, sir. We just keep a drain and we come out and we observe the patient for, we start fluids in 8 hours, sips of fluids.
Yeah.
And we start clear liquids the next day after 24 hours. And
Mhm.
then we observe patient. Once the patient passes stool, we usually advise second day, we advise a Dufalac. And after at 36 hours, we advise Dufalac. And then we see how the patient is. Once she passes stool, if there is no symptoms and if we don't see any tachycardia and all, then we will remove the drain also.
Okay.
Sir,
Because,
so
yeah, go on, please.
sorry, sir, you speak, sir. Amey sir wants to say something, sir. So after you can.
नहीं, Amey sir, please come in. Amey sir, बोलिए please.
Yeah. Thank you, JP.
Yeah.
Dr. Vidyasagar, excellent video. I
Yes,
just
sir.
wanted to make a comment here.
Yes, sir. Yes, sir.
Basically, I don't do much of resections, but in my practice, what I have observed that the mucosal involvement is almost nil in the patients which I cater to.
Yes, sir.
It is always possible if we do very delicate dissection of the nodule, you
Yes,
can
sir.
almost conserve the mucosa, and then you can reconstruct the muscularis.
Yes, sir. Definitely, sir.
And as a thumb rule, what we do is we are using a rectal probe. Okay,
Ah,
the
sir.
probe is used to identify the rectal wall when you're in doubt.
Yes,
So
sir.
the diameter of this rectal probe is roughly 28 millimeters or around 30 millimeters.
Yes, sir.
If your rectal probe can be passed beyond the site of the nodule,
Yes, sir.
you have a good lumen available.
Yes,
And
sir.
it
Definitely.
generally doesn't require surgery in the form of segmental resection, and you can preserve the neural innervation of the rectum and get rid of all the dreaded complications which Ashish sir was mentioning.
Yes, sir. Definitely, sir.
One more comment. I was observing your conversation about the involvement of the ureter.
Yes, sir.
We have to understand that the ureter is a mobile organ. It keeps on peristalting all the times.
Yes, sir. Yes, sir.
When you get extrinsic endometriosis, Okay, primary endometriosis of the ureter is very, very rare.
Yes, sir.
I have never seen it. I did see one video, I think it was shown by Dr. Sanjay Patil sir in one of the events only.
Yes, sir.
Never encountered it. So it is secondary endometriosis which keeps on forming a fibrotic nodule around the ureter and constricts it, and over a period of time causes damage to the kidney, which you properly highlighted.
Yes, sir.
So, as it was discussed, that if you split the nodule with the help of scissors, as JP did describe it very clearly,
Yes,
when
sir.
we split it, we are able to see the other end of the nodule also.
Yes, sir.
So we can actually cut it out in two pieces.
Yes, sir. Yes, sir.
That is what I just wanted to highlight, that
Yes.
if we are able to avoid a use of energy,
Yes, sir.
it is helpful.
Yes, sir. Yes, sir. When there is a very tight constriction, severely, obstructing the ureter, then definitely this seizure would be more beneficial, sir. Rather than using any sources, then it would be helpful to do with the seizures. Even when we are dissecting the ureter, if we are using an harmonic, it is advisable to dissect, keep the vibrating blade outside, so that the injury to the ureter will become much more lesser, sir.
Yes, thank you.
Amey sir.
Yes, sir.
Yeah, JP here, sir. Sir,
Yeah.
आपने जो बोला that you use a rectal probe. Off late, I have also started doing that.
Yes.
What it does is it nicely shows you how much tissue is actually fibrotic and how much is actually supple.
Yes, yes.
The moment you shave off the fibrotic part, and
Yes.
the moment you move the probe in and out in the rectum,
Yes.
it tells you whether still you need to remove or you have done your job.
Yes, you're right. And
So
one more fact I just want to highlight. See, if you see all the EEA staplers, end-to-end anastomosis staplers by Merrill, by Covidian, or by Johnson & Johnson, all have the maximum diameter of 29, 31, or maximum 33 millimeter.
yeah.
So we have to understand that the circumferential, whatever the perimeter is never more, or the diameter is never more than the average of 30 millimeters. So if you are getting that lumen, it does not warrant a segmental resection with its dangerous risks, which are going to affect the girl. Because see, we have seen elders in our family and all, how their bowel habits matter to them. It is an extremely excruciating, emotionally unstabilizing event in any individual's life. So we
Yeah.
have to take it very cautiously about taking the decision for a radical surgery such as segmental resection. Unless there are skip lesions or multiple lesions or a very constricting lesion, then only. And a dynamic difficogram, an MRI difficogram, as you have already discussed, inserting the ultrasound gel into the rectum, will help outline these things better. And a difficogram sometimes will tell you whether it is really obstructing the passage of feces. If not, you should err on the more conservative approach, which Dr. Ashish highlighted.
And also in patients where we feel that where there is an intrinsic involvement, one can also opt for colonoscopy. Like we can do that also, sir. But that is very where we are sure of we are going for resection and where there is an intrinsic involvement, you can do that also.
Yes, that was helpful. Yes.
Actually,
Thank you
colonoscopy.
for the discussion.
Yeah. Colonoscopy, many surgeons and gastrosurgeons who are not really well versed with the rectal endometriosis seem to think that, for superficial, like, when it is involving only serosa or seromuscular area,
Yes,
they
sir.
want to do a colonoscopy to diagnose the endometriosis. No, colonoscopy will not help in those cases.
Yes,
As you
yes.
rightly mentioned, say when you want to see whether the mucosa is involved or not, or whether you want to decide whether there is a too much of constriction where you want to do a segmental resection and like that, such cases colonoscopy is justified. But otherwise, just to diagnose a rectal endometriosis, doing a colonoscopy or sigmoidoscopy is actually waste of time and
Yes.
resources.
Definitely, sir. Definitely, sir.
Yeah, because I had to argue with a few gastrosurgeons to tell that Baba, your colonoscopy is not. No, they said no, get a colonoscopy done. I said no, it is not going to help us.
Yes, definitely, sir. Only the intrinsic involvement patients
Yeah,
where
yeah,
we are more assurance is required for resection and anastomosis, we can go for that.
yeah. Fine.
Dr. Vidyasagar, one
Sir,
question.
hello, sir. Good evening, sir.
Anil here.
Yes, sir. Yes, sir. कैसे हो, sir?
The question from JP, one of the questions, it has gone unanswered.
Yes,
Means,
sir.
have you seen any changes in the treatment modality in last 2 years, or whether he has mentioned, Dr. Patil sir has mentioned about it, like earlier, whatever you used to do, like discoid, now you have started doing shaving for it, or earlier you used to do shaving with harmonic, now you have started using scissors, something like that.
No, sir. Actually, the approach and this thing has not changed. Only thing that
Okay.
what I have seen is that sir has gone more towards the organ preserving surgery. We used
Okay.
to see that even if nodal, if it is less than 8 centimeter, also we used to sometimes we used to say that we have to do from the anal verge we have to go for ileostomy and all. Now we have done even the lower end resection and anastomosis also, which came through good. And we are trying to preserve as much as possible. We are trying to preserve, go for less radical procedures. We prefer shaving. We prefer going for a discoid. Suppose if it is not happening, we try that. If it is not happening, then the final solution is the radical procedures, sir. So now, sir, try to push for more regarding organ preserving surgeries. And second thing is that regarding instrumentation, sir has fixed this, and he is very well, was with harmonic instrument. But when it comes to tight situations where the chances of injury can be there to surrounding structures, he goes for scissors, just like that. There is no change in approach regarding the instrumentation, sir.
Okay, thank you. And one more thing,
Yes,
how
sir.
many cases of this bowel resection anastomosis or shaving or discoid, they have come back with recurrence recurrence of endometriosis in bowel again?
Yes,
And
sir.
what is the approach for that?
Recurrence, suppose if we are going for a radical procedures, I have not yet seen any recurrence. If we remove both uterus and ovaries, that the recurrence is very, very less, sir. We have not seen any kind of that. Suppose even for the bowel nodule, as I have been seeing this since 2 to 3 years, that the chances of recurrence of bowel nodule is very less. It takes long time for this nodule to grow, sir. And only the very active kind of disease where proper this rectovaginal plate, as I mentioned, if it is not removed, and if this colon has not been shaved, then chances of coming with recurrence is more. But with our center, what sir does, I have not seen any recurrence with regarding colonic nodules, sir.
Okay, thank you. Thank you, Vidyasagar.
Thank you, sir. Thank you.
It was excellent presentation and good discussion, I
Sir,
must
thank
say
you so
that.
much, sir. Thank you.
Yeah, okay.
Sagar, after the conservative surgery, like for example, for fertility, you have done the deep infiltrating endometriosis excision, adhesiolysis, and then even maybe rectal nodal shaving, vagera.
Yes, sir.
Now, what is your follow-up? Like, do you tell the patient, okay, you should go for IVF, or you tell them, okay, you can try conservatively? Number one. Number two, when do you ask them to go for fertility treatment? Number three is like, do you put Dynogest or what is the Lupride injection? Or nowadays, many people are putting this dydrogesterone tablets. What
Yes.
is your preferred mode of follow-up after surgery?
Yes, sir. Yes. So here, basically, any patients come to you, either comes to you with a rather pain or an infertility. So irrespectively, most of the conservative surgeries, patient wants to conceive. Irrespectively, only less than 2% are for something else. So in these patients, we always advise that first thing is that AMH level doesn't correspond to what is the ovarian status, whatever it is there. AMH is as such is low in endometriosis, and AMH refers to development of primary follicles rather than an ovarian reserve. So whenever there is a surgery that has been happening, depending on how much part of the ovary is retained, suppose if it is more than 50% of the ovary retained, then it is a good for the patient. And second thing is that these patients, once we do this surgery, once we remove all the endometriotic nodules, we prefer to give the GnRH injections only one dose, 11.25 at 10th day. So these patients will have 4 to 5 months of amenorrhea, and we advise them once they resume their menses, they can try naturally for 3 months. Suppose if more than 50% of the ovarian volume is retained. Suppose if less than 50% of the ovarian volume is retained, it is better them hurry up and go for procedures like IVF and everything. And we also counsel that when patient, like counseling plays a significant role in this. Sir and institute, this institute says that 30 to 40% of the patients will conceive naturally if ovarian volume is good, and 80% of the patients with total patients with endometrial surgery can conceive with assisted procedures also. So basically, patient has to now the solution for the patient is either go for a radical thing or conservative thing. Suppose if patient is going for a conservative thing, patient should be counseled that if this pregnancy is not happening with your womb, then patient should also be ready with pregnancy with an womb donation. Till that level, patient should be counseled before opting for conservative surgery, sir.
Okay, thank you. Any other questions? Anyone else want to ask questions? Otherwise, we'll wind up.
Hello, sir. Can I say something, sir?
Yeah, Raju.
Thank you, sir. Thank you, Vidyasagar. It was very nice.
Thank you, sir. Raju, sir.
I still okay with the imaging modality that we are using. Yes, we are using ultrasound. One thing I wanted to add, sir. I used to always trace the muscularis propria, and it is having two layers, outer longitudinal and inner circular layer with in between a hyperechoic band in that. So I keep looking at the bowel nodules. And one such discussion I had with an endometriosis surgeon as well as a gynecologist who came to the Mala Sibal's conference in Bangalore. I asked him on based on what criteria and ultrasound we will be able to diagnose to go for resection or shaving. So he made a point saying that if the nodule, if you closely observe, they are not actually penetrating the muscularis, most of mucosal layer most of the time. They will be usually in the level above the intermediate line, that is muscularis propria, that is outer longitudinal layer. Only if it is involving the inner circular layers, then you have to be more cautious. That is the time when you can think of going for resection anastomosis. But if you keep looking at the middle line, it will be the nodule will be usually above. So that I am retrospectively looking at majority of our cases, we have not gone for resection only. Definitely, most of them it is done by shaving only. This one point I will be taking it, sir, so that we will look forward. Though it is very early for me, so I'll keep looking at that line and then try to analyze better, sir.
Yeah. So what we can do is whenever you are reporting, so we can mention it in the report with a bold letter saying that this is what it is.
Yes,
And then we will operate such cases, and then we will see that whether how much was your involvement and whether she actually required only shaving and to what level, and if at all it was bad enough that we accidentally open and all that. Okay, we'll keep observing these things in future.
Yes, sir. Yes, sir. Yes,
Yeah,
sir.
Raju. Yeah. Any more questions? Okay. Sagar, thank you very much.
Thank you, sir.
It was a really wonderful discussion, wonderful surgery, and also, wonderful question answer session.
Thank
So
you.
thanks
So much, sir.
everybody who has joined, and this whole discussion will be available on YouTube in my channel. I'll
Yes,
be
sir.
sharing it in the group so that anyone who